All right, welcome everybody to our session today on tools, technology, and expertise. It's great to have you all here today. We have some excellent speakers lined up for you for this morning. Some really nice talks ranging from epidemiology to testing with tools and expertise that hopefully can help in all of your communities, and looking at skills, tools, and resources that can be helpful in everything from a school environment to local public health systems. And so with that, it's my pleasure to start off the session. And our first talk today is going to be from Harold Hastings. And Harold is a mathematician and dynamical systems scientist at Bardge College at Simon's Rock, and he's going to be talking to us today about the math of COVID virus transmission with the perspective of mitigation strategies and ideas for reducing the spread of epidemics in the future. Harold, it's very nice to have you here today, and I'm turning it over to you.
Thank you, Jeremy, and I want to thank the organizers and everyone here. And let's see, there we are. So I'm going to talk about the math of COVID transmission. I want to thank Tai Young for coworker, and my older son, Curtis Hastings, for checking out some of the matrix mathematics with me. We are in the midst of a global pandemic. The only one this bad in the last 100 years was the flu epidemic in 1918 following World War I. And one thing to remember is the probability of a 100-year event in the next 10 years is about 10%. So the fact that the last event before this of this severity occurred 100 years ago is not comfort. It should rather serve as a warning to us. Take-home points here I hope to show you. Control early, think log scale, think logs of the number of cases. Doubling from 200 to 400 is like doubling from 2,000 to 4,000, Massachusetts daily. Driving it down is the same effort, but if we can keep it at the lower numbers, at the 400 to 200 range, we won't overload the health system, reducing mortality, and have a number of good effects. The system will function better. You may recall acceleration from the talks yesterday. If you plot on a log scale, acceleration is just the slope of the line, and roughly speaking is proportional to the difference of RT and 1. It's a question of what scale you measure on. I want to emphasize that RT less than 1 is not enough. You really want to get it significantly below 1 to have good effects. I'm going to argue we want to think of networks and hierarchical models, and the unit of infection may be the family or the pod or a larger group. It's more than the individual in public health. And we want to look at redesigning cities to really attack this. Cities have been engines of economic growth. Everything scales in cities. The productivity scales, that's good. Wealth creation scales, that's good. Crime, pollution, disease also are higher per capita in dense cities than in rural areas, and we want to get the good effects without the bad effects. So we're hoping to reimagine, and I'll give some hints of how one might redesign cities in the future. As Elizabeth Stinson said, health and disease have always shaped our cities. Cholera epidemics that plagued New York in the 1800s, and I'm going to ask what should be the impact of COVID-19 on design. I'm presenting very, very simple math models. Epidemiologists, stochastic people, and so on will recognize the simplicity. I'm neglecting a lot in the interests of time, in the interests of being able to explain it. But as Bob May and Roy Anderson described in controlling the HIV epidemic in San Francisco, simple models can help inform strategies. So I'm visualizing a city of the future which combines real and virtual, although there's not necessarily anything unreal about virtual, but combines non-web and web interactions to try to gain the productivity that we see in cities by reducing the cost of interactions, work of Lou Betancourt there. This was a picture of the basic model, the SIR model, susceptible, infectious, removed. And let me say that there are fancier models. I'm just going to restrict it to this. And as was shown in New Zealand, Australia, South Korea, China, hopefully you can drive the susceptibles. They're down here in the bottom, in the right graph, down to 0. And in fact, we were very, very optimistic in April and May and failed to do so. So the model, basically, I'm looking at the flow in and out of an infectious compartment, and it's a mass action rule. There's some sort of effective contagion rate, B, that will depend on all sorts of things, the nature of interactions, the nature of the virus, masking, distancing, all sorts of things. But basically, there's a mass action rule when a susceptible and an infectious meet. And I'm going to just take a very simple model for people losing the ability to infect others. And removed here relates to either recovered or tragically passed away. And I'm neglecting the loss of immunity. There are a lot of simplifications here that people will recognize, but this is like a point model or a mean field model. And the goal is to make the infectious 0 steady state. If there were no infectious, it wouldn't propagate, but to make that steady state stable, that's the math formulation. So you write down some equations, and I look at the infectious at a time later at, I don't know if can you see a pointer? At time t plus d, and you can write down an equation for it, which includes basically the RT you're familiar with. I'm warning you that I'm neglecting time delays. That symbol is the European road sign for dangerous intersection or dangerous curve ahead or whatever, a warning sign. So I'm neglecting certain features here in this model. I want to note that the rate, which looks like it's just a constant times susceptible times infectious, really depends on the nature of interactions, and that there are super spreaders around. As May and Anderson pointed out, we're interested in more than the mean number of interactions. People with large numbers of interactions have a disproportionate effect in spreading the disease. What does this have to do with networks? This is a picture from a Massachusetts optimist giving a public talk back in August, when it looked like the red states had low infectivity rates and we could travel to them, and the white states did, and the red states had high infectivity rates. But the point is that we really want to deconstruct, we want to localize, we want to think of the processes as taking place locally and then spreading from site to site. So a tale of two cities, a sort of crude analogy, Redville with a growing disease, an R of 1.1, Greenville with 0.9, and it dies out. But once there's a link, which causes cases to flow from infection to flow from Redville to Greenville, suddenly you observe that the number of infections in Greenville starts to grow. So we really need to think networks, to think flows, to think the unit of infections. And so we have a matrix model. A matrix is the way to represent interactions in a network. It's a little bit of a change of notations. I'm going to try to kind of go through the math rather quickly, but I want to just emphasize a few points. This MII term at the bottom, that's the number of infections at site I generated by an infection at site I, one step later. And the other terms represent flows from site to site. So we really update this. This is not very different from what one may be used to, but it's now representing the spatial distribution of infections. And so we can think of some of this as a fine-grained, a local SIR, susceptible, infectious, removed model, and an effective flow parameter from place to place. And these are the components of a fine-grained growth rate. We really should be using a multi-network structure. Note that many of the infections, if one person in a family group is infected, it's very likely that others are, that many infections occur, particularly with an asymptomatic case in a family group. So that's an extension to this work. And we have an update rule, and what's going to play the role of RT over the appropriate time is you just look at the number of infections produced by one infection in all locations after one time step. And that's the sum over a column. And so as a geeky mathematician, I realized, gee, this kind of looks like stuff I learned in probability theory and the Gerschoren theorem. And one can, in fact, look at a substochastic matrix. Each case produces less than one new case everywhere, wherever it is, and a superstochastic matrix where each case will produce more than one, wherever it is, at least from one site. So if all sites produce less than one, things will die out. And if one site produces more than one, that can sustain the infection and then drive it elsewhere if the system is more connected. From previous work in ecology and epidemiology are two sides of the same coin. In one case, you want to keep the rare species alive. In the other, you want to drive it to extinction. So I think we can learn a lot from work of matrices in ecology. So here's the picture. We're going to look at the number of cases produced everywhere, irrespective of location. In other words, not just Massachusetts RT and Rhode Island and Connecticut, but take into account flows between regions. Note there's a debate going on about the cross-border US-Canada traffic from, for example, trucking. And Matthews, there's a bunch of precedents to this work in many generalizations. So implications for control. After all, we're really here interested in trying to control the spread, and we will need to control it before we get enough vaccination, although vaccination is helping reduce the likelihood of running into an infectious, a susceptible and infectious meeting. Basically, an infectious won't spread to a vaccinated and immune susceptible through a combination of bounding local rates and circuit breakers like you use in the power industry. And we think of those as lockdowns and travel restrictions. So really there's a fair bit of math to go behind this. I want to note that you really need to look at variability. You can look at a stochastic model for relevant to the discussion before. I don't really want to say much about this other than what you notice in the denominator of this last equation is that if the growth rate is just a little less than 1, if it dies out slowly, each case will produce a large number of new cases. If RT is 0.95 in that model, one case will produce 20 cases downstream on average. The other challenge is this is a cascading failure. The spread through the network is much faster than our ability to react. This was emphasized in a number of talks based on both the way we accumulate and measure data and the fact that there's a period of potentially being infectious without knowing it. Why model cascading failure? We need to act faster. There's a second reference that I didn't get to put in time about screening in universities that has kept the spread low at Cornell from a talk yesterday, and for example, kept the spread. We had no cases at Bard at Simon's Rock this fall from a rigorous testing program. So just an encore look, we are in the midst of a global pandemic and these will recur. Cities are engines of economic growth and reducing poverty. We will see the growth of cities in the future. We see increasing urbanization. Health and disease have always shaped our cities, and this will continue to shape our cities. The question is, where will we end up after this Zoom era? Simple math models can elucidate the dynamics, and we're looking at some of the dynamics of simple math models. What I want to emphasize for public education, and I will admit I don't know how to do this, is to try to tell people that an increase in case rates from 200 to 400 per day, Massachusetts in the summer, produced just as bad an effect as a later increase from 1,000 to 2,000. that if we kept it at 200, we would have kept all of the other increases at lower levels. So a log scale that tends to prevent low case loads from looking like they're just wiggling at the bottom of a giant graph would be very helpful. I'm thinking of a city of the future, which would be arranged so that we would have a variety of in-person and virtual interactions, where we would try to retain the productivity, but without the cost and spread of disease. And in particular, Schlaffer had looked at some cities in Portugal where he had data and said there's some universal scaling, but reducing the in-person contacts. As you see in rural areas, you get the same universal scaling, but in this graph above the map and to the right of the New York City picture, the blue areas represent areas where we've reduced the number of human contacts. So that would be a goal for planners, and to try to figure out how to make it work. In particular, for example, we could visualize local interactions, schools, cafes, whatever, things that make a city really work, and virtual interactions for exchanging ideas and long distance interactions. The red lines being both the long distance, the virtual interactions, and short distance virtual actions in areas where you would need additional circuit breakers. And with that, I just want to summarize some of the points I hope I've emphasized and explained from the models. Control early. Think about a log scale. Use that in all your presentations to people. Understand acceleration is a key indicator. I am disappointed, as many far more knowledgeable epidemiologists are in our Governor Charlie Baker's easing things up, when it looks like our acceleration is roughly zero. We really shouldn't begin to ease up till the acceleration is decidedly negative. You're going down a hill, you don't sort of ease off the brakes when you think you've controlled overspeed. You try to produce a safety factor in there. Think networks, hierarchical models, what's the unit of infection and how to control, and to try to redesign and reimagine cities and how they work, as people did to defeat cholera, to control disease while continuing productivity. And with that, I'm thrilled to be here and have the chance to learn from many people and get going on working together and seeing actionable items in the future. And from the math side, what we would like to do, there'll be some future publications on multiple and networks and other things, generalizing this, putting in variability, fat tail distributions and heterogeneities, and then trying to go from dynamics to design. And with that, I want to thank everyone very much for listening, and thank my colleagues, Tai and my older son, for helping out in getting this done. And this really is a joint effort of many people. Thank you very much.
Thank you very much, Harold. It's very interesting talk, and of course, very relevant to what we're talking about now, but with a nice perspective looking into the future, what we can do to try and set things up so that we don't have the same situation again. So we're happy to take any questions. If anybody has any questions, please feel free to put them in the chat. Also, if anybody has follow-up questions for any of the speakers today, please feel free to sort of continue placing them in the chat, but also we will have the Slack channel, and this is the testing, this is the tools session tools 1 Slack channel, and where we will continue this conversation. So please, questions are very welcome. And to get things started, Harold, you know, sort of one real question is, when you're thinking about sort of cities now that sort of go back and forth between sort of hard lockdowns and then sort of middle ground restrictions, you know, what's your suggestion for what can be sort of reimagined or redesigned within cities right now that might help?
Well, one thing I think is to try to understand where COVID is really spreading from appropriate testing. I really don't know a lot. I think I am, for example, firmly in favor of reopening the schools because I think the losses are large, but I think the literature, some people say this hasn't resulted in increased infections with control. On the other hand, people have observed that when universities closed before Thanksgiving, that this was associated with a decrease in the case rate. So that's part of it. The second thing, it seems to me, is to try to do a cost-benefit analysis on the economic impact, remembering that economics, if it affects whether someone can get medical care, food, heat, whatever, affects health, and that the education will feed back on children and the rest of us all in the future. So to try to look at this and ask, can we be more intelligent in our control mechanisms? And the other thing that I think is that if I imagine that I have a lockdown that drives, say, RT a little below 1, Massachusetts, the last data was 0.92. I don't have local data on Boston, for example. And then we ease up, we're only going to have a short period where things are open and business can't really start and stop. So maybe what one really needs to do is look at trying to operate in a safer zone where we are maintaining the caseload low and RT below 1. In other words, think of driving more conservatively in bad weather. And the other part is to begin to think about, how do I manage to preserve the interactions we all value while minimizing the potential for what might think of as risky interactions that might well be doable in cities. One, in fact, is seeing measures in public transport. One sees measures in post offices, libraries, city structures. But thinking about the things that I love in Boston, as someone from rural Massachusetts, for example, can we safely reopen museums? How can we do this? Can we sponsor activities in the park? Can we foster human connections and interactions? And at the risk of running on too long, let me note that the talk on the care home, Shady Grove, that I was thrilled by, I read about that in the press, that the interactions play a critical role in people's lives, and we need to do everything we can to do it. Some of the redesign will take time, but there are measures we can take now to make things safer. Universal masking alone is one. The redesign is more over a period of time. When you rebuild a transportation network, if you're going to build open areas, if you're going to build new schools, you put the ventilation in to have where you locate public health facilities, things like this. I mean, just think about the city as a collection of connected small villages. And Tai knows much more about this than I do.
Thank you very much. That's it's a very interesting topic, and really, really nice to be thinking about what we can do now and what we can do for the future. So thank you very much, Harold. And we will now move on to Patricia Kearney.
I will unshare and mute if I can figure out how to do it.
And all right, so thank you very much. It's now my pleasure to introduce Patricia Kearney, who's a professor of epidemiology working in population health and health services research at the University College of Cork. And she's going to be talking to us today about her experiences in going from an epidemiologist to an armchair advocate in Ireland. It's a pleasure to have you here today.
Thanks, Jeremy, and thanks for the opportunity to speak with you this afternoon in Ireland, in the morning, I think, for many people tuning in. And I thought I'd start, this is a photograph of my niece, Lucy Patricia O'Brien, She is 7 years old, and she is, as you can see, expressing pure joy there at seeing her auntie, her godmother, on the television. So that's me in the background, and I was at the time addressing a special committee, and so I was up in the Irish Parliament, and it was a special committee that had been convened to look at our COVID-19 response. And so I wanted to talk today a little bit about how I, as an epidemiologist, ended up in this position, and sort of really very much out of my comfort zone. And so, yeah, I'm going to talk a little bit about my kind of happy place, which is epidemiology, and how, you know, we've heard a lot in the past year about armchair epidemiologists. And so I'm going to speak a little bit about what it has felt like to me in taking on this role of what I'm calling an armchair advocate. And I suppose unusually for me, so often when I'm talking or teaching, you know, my starting point is, well, what is epidemiology? And, you know, if you think back to a year ago, many people didn't know what epidemiologist was, what epidemiologists did for a living. I particularly like this definition from the dictionary of epidemiology about the distribution and determinants of health-related states or events in specified populations. And importantly, and I do work in public health, you know, that this knowledge is then applied to the prevention and control of health problems. As you can imagine, I'm often asked this question, you know, what do you do? In the back of a taxi, back in the days when I took taxis, or at the hairdresser, back in the days when hairdressers in Ireland were open. And so I don't think they'd have been that happy with that definition. So actually what I would usually say, long time ago, back when I was studying for a master's in public health in the US, I'd have been saying, have you seen the film Outbreak? Or more recently, I'd have said, have you seen the film Contagion? And then explain, well, that's what infectious disease epidemiologists do, but actually I'm a chronic disease epidemiologist. So I do that for diabetes and heart disease. And at that point, usually the hairdresser would say, well, and did you go out last night? Or try to find some other conversation to take me away from the details of being an epidemiologist. So I suppose I'm starting with that to give a bit of context, in that at the start of this pandemic, I was very conscious that I am a chronic disease epidemiologist and had not worked in infectious disease epi. But over the course of time, I became aware that as an epidemiologist, I did have access to some expertise, context, and knowledge that was helpful in terms of understanding where we are. And unfortunately, in Ireland, where we are at the moment is not a great place to be. This slide is produced by our Health Protection Surveillance Centre, and it's quite a nice, apologies, you know, the writing I know is quite small, but I would ask you just maybe to look at the first graph there, and that essentially, it's, you probably can't see the months there, but that's essentially a year. So where we went from January 2020 to January 2021. And, you know, we did a pretty good job actually in terms of suppressing the virus early on. We got the numbers very low. And then you see we had a second surge, and now we're still really in the midst of our third surge. And we had very high numbers here. Our hospital system came very close to being overwhelmed. Our ICU capacity has been stretched beyond its surge capacity. And so the reason I mention all of that is to explain, I suppose, how that has motivated me to become this armchair advocate. So one of the things, this is, you know, what went right maybe early on. This was some work that I had done where we just looked at the number of cases from that database from the Health Protection Surveillance Centre. And you can see that the case numbers were increasing, relatively small numbers of deaths, the numbers of case contacts increasing over time. And I point to that because one of the things that was happening in the background was various different public health interventions to try and control the pandemic. And the reason that I mentioned those public health interventions and even just this distribution of these cases is that these are the kind of graphs that really anybody could go to the Health Protection Surveillance Centre extract the data, and we have quite a nice interface now that's publicly accessible with the data there, and you know, lots of people are accessing it and analysing it, trying to interpret it. And early on in Ireland, one of the questions that was being asked was, well, why can't we be more like Sweden? Now, we've all seen what's happened in Sweden, and people aren't really asking that question anymore, but certainly in Ireland a year ago, it was more in the UK, but to a little bit in Ireland, asking, you know, why are we even having these lockdowns? Why are we making these decisions? And one of the things, and it goes back to the distribution and determinants, is understanding that there's always so much more going on behind the numbers and the graphs that we're looking at. And so, you know, while we might like to compare, for example, one other country, Sweden, just one thing that we look at, and the number of households, and we know that household transmission is a huge driver of the pandemic, and there's a huge difference between Ireland, which is in green there, which is in terms of the proportion of households with only one adult, compared to in Sweden, which has the highest. So in Sweden, 63% of people, and there's only one person in the household. So in terms of the things that we know that work, like social distancing, you know, you're having to manage your pandemic in very different ways in different countries. The other thing that goes on behind the case numbers and the kind of low numbers that we saw early on, this is a case from a city that I'm from, and basically these people broke the rules. So what they did was they went and tested somebody, a suspicious case, for COVID, even though it went against national guidelines at the time. The reason I mention this is because early on in the pandemic, so back in March of last year, I'm a physician by background, and so I was seconded to our health service because there was suddenly this huge and for people to work in public health, that there was no community transmission. But the problem was, and I think I have this here, is that in order to be tested for COVID-19 at that time, you had to be in contact with somebody who had COVID, or you had to have been to mainland China. So we had no community transmission, at least in part because you couldn't be tested for COVID-19. And I mentioned that because it's these sorts of details that are my raison d'etre as an epidemiologist, and thinking about the reasons behind numbers, but sometimes we don't always have all that specifics available to us. And so when we look at the numbers early on in Ireland, the access to testing was extremely restricted because, you know, it was a new disease. We didn't have the labs, we didn't have the capacity to do it. There was a huge increase in capacity, numbers started to go up, and then the capacity got overwhelmed. And so all those sorts of things impacted on the epidemiology of the cases at the outset of the pandemic. And so that's one of the things that I have to do here to, and when we're looking at this, so this is basically the first 6 months last year, you see this increasing number, and understanding there are things that are going on in terms of public health interventions, closing the schools, telling everybody to stay at home, that was actually impacting on the way that the virus was being allowed in terms of its transmission. But then as well as that, there were all sorts of other health service considerations in terms of things like access to testing, which also impacted on the epidemiology. And so I think, you know, back in about March of last year, I remember in the New York Times, because I was asked why Ireland was doing so well, because, you know, we did manage to suppress it to, sorry. Sorry, this is the joys of working from home. So the, you know, this is the kind of happy story, I suppose, and going on really from what Dr. Hastings was saying was the importance of sticking with what needs to be done and understanding to me, the kind of danger time, which is what happened in the summer. The numbers came right down, the sun came out intermittently, you know, people wanted to go on their holidays, and despite our best efforts, so myself and others involved with, we did call ourselves Zero COVID Island. Then more recently, we kind of rebranded as the Independent Scientific Advocacy Group, and we were really calling that we needed to stick with the measures if we were going to get the numbers right down. That's just more on the complexity, I suppose. And the problem is that the number to come back up again. And so the image that I showed you at the start of the talk from of me at the special committee was in here in August. And so what we saw was that very clearly, as the measures started to be eased, the numbers started to pick up. And I suppose one of the things that I found extraordinary is that it was so obvious that that's what was going to happen. And I suppose what's taken me nearly a year to really understand is that it wasn't obvious to everybody. And that, you know, working in public health and epidemiology for 20 years, you know, some things that are obvious, if you had that background, are not as obvious to everybody else. And so, you know, what do? Well, you get out of your armchair and you get up to the Capitol and start talking to the people who hopefully might listen. So one of the things that we've been doing is regular webinars, and one of my colleagues, Paul Dempsey, who's a mathematician, has been creating these maps where he looks at the data to try and convey sort of what's happening in Ireland. And one of the problems with the county level data is that you can see that, you know, there's a bit of a delay, and this goes back to the understanding the epidemiology, that there's a delay in terms of what we're actually facing now. So when we see the numbers start to creep up, it's almost too late for action. So that back to, again, what Harold was saying was that you really need to act early and you need to get ahead of the virus. So I'm not going to go through, this is always want to throw in some of the research that I'm doing myself. This is some work that we did last year where we looked in a nationally representative sample about adherence to the public health measures. And I suppose to me, the important message here was, so these are percentage of uptake by county, and these are all above 50%. And so the message here is that there was huge levels of individual responsibility. And so on our television, most days we're hearing from our politicians the importance of personal responsibility and adhering to the strict measures that are being introduced. And what the voice, I suppose, that I've been trying to find with my colleagues is to call on our leaders to show political responsibility to make the difficult decisions that they need to make, you know, to try and keep the virus out. So I'm conscious, I think I'm way over time, to just mention, because, you know, you may not be familiar with what's been happening in Ireland. So in Ireland, the strategy essentially is this one of living with the virus. I heard it, somebody earlier on another webinar I was on talk about the misery of mitigation. And so we've been yo-yoing between these sort of level 4, level 5 lockdowns. At the moment, we're restricted within 5 kilometers of our home, working from home, our schools are closed. And as this part of this group, the Independent Scientific Advocacy Group, we've been really arguing for an elimination approach. And it's taken some time, but I think we're getting real traction now. And it's clear that the scientific evidence is there. We clearly now have the population behind us in terms of the most recent polls in Ireland. 90% of people are calling for an elimination approach, but we're still trying to get our politicians on board. And we've brought in speakers from different countries to learn from their experience. And so I suppose I wanted to finish up. This is me on the train. Back in August, on my way to Dublin, with using my voice, but I think there is a responsibility there, and I'm glad to be part of this group advocacy. I acknowledge my colleagues in ISAC. Thank you.
Thank you very much. Yeah, there is that real responsibility that I think we all share, which is why we're all here today. So it's nice to hear. So does anybody have any questions? So there's a question in the chat. Ireland would appear to have many of the same advantages as a nation like New Zealand in terms of control, with the major difference being the shared border with the UK. How much do differences in control measures between Ireland and the UK governments impact the spread on the island as a whole?
Yeah, so there's, I think our border with the UK has been a major challenge, and certainly the line that we've heard from early on, and when we've tried to propose an elimination strategy, has always been, well, what about the border? And one of the things that we've done now is try to develop a clear plan with bubbles around the border. Ideally, and from the start, the group that I'm involved with has been north-south, and we've wanted to take an all-island approach. And I think the population, the scientists, you know, we're all happy to work together. With the politicians, it's a bit trickier. And one of the other things that's challenging is, and as going back to the question, is that the approaches have differed. So for example, up until very recently in the Republic, we were testing all close contacts of confirmed cases. Whereas in the North, they were only testing symptomatic close contacts. And so the other thing is, you know, along the border area, you have people who might live on one side of the border and work on the other, and, you know, with different restrictions and different guidance, you know, even things like the symptoms in terms of indication for testing, they are different between the North and the South. So it certainly does make things more difficult. And the of the infection, and going back to that idea of the movement, you know, from a high area to a low area, what's happened is that the pandemic, the sort of distributions have varied a bit between North and South. And so then the lockdowns have varied. So then, of course, you know, if there's a strict lockdown in force in the North, then people will move, do their shopping in the South, and then things get worse in the South. And so it certainly hasn't helped. And the ideal would be that we would be taking an all-island approach.
Thank you very much. In the interest of time, we'll now go on to Ed Campbell, but thank you very much for a very interesting talk. All right, so it's my pleasure now to introduce Dr. Ed Campbell, who is a professor in the Department of Microbiology and Immunology at Loyola University, and is going to be talking about his recently created organization, Safeguard Surveillance, that performs surveillance-based testing in K through 12 schools in the Chicagoland area. It's very nice to have you here today, Ed.
Thanks a lot. Can I ask real quick, can you see my real presentation screen or my speaker view?
Both, it's the speaker view.
Oh, okay, all right, hold on.
Hi there, good thanks. Oh no, sorry, I was on a
That's going to be the same thing. Now you can still see the speaker view, can you not?
Yes, can still see the speaker view.
Come on, what's going on? The screen sharing format here is just a little bit different than I'm used to. I apologize, advanced. I just want one screen. I just want one screen. Okay, well, we will just do this the old-fashioned way, I guess. So, yeah, thank you very much. And I'm very pleased to be here to talk to you all today about what we've done in Illinois to do COVID surveillance testing in schools. And so as a bit of a prelude to what I'm going to say and why I'm going to say it, I've just highlighted here some perspectives that have been in the New England Journal of Medicine or from the American Association of Medical Colleges, which highlight the need for rapid testing as a surveillance tool to both ensure school safety and also to really prevent the spread of COVID transmission in our communities. And so when we started to think about how to approach this problem, really it was the thinking of people like Michael Mina and Roy Parker at Harvard and Colorado, respectively, who have been making the point for a number of months now that America's approach to testing is somewhat misguided because effectively we've put all of our eggs in the sensitivity basket. And what they argue is that, and this really came up in the last talk where Patricia was talking about people not being able to access a COVID test unless they were so obviously exposed that they almost probably don't need a COVID test because we know they're going to be positive. And by making tests cost effective and rapid, this allows the testing of a greater swath of the population and thereby identifies infected people, pre-symptomatic. All of the people that we've identified so far in our testing that I'll tell you about 80% of them have been in the pre-symptomatic or asymptomatic phase of infection, which means they were walking around infectious but didn't know it. So I can now testify that this logic, I think, is very sound. And so when we think about lower sensitivity, that seems scary, but really it's the fact that people that are infectious have a wide range of viral loads. And it's known that around 10 to 20% of people that are infected have a much lower viral or a much higher viral load than the majority of other people that are tested. And this 10 to 20% of people are thought to contribute to between 60 and 80% of the next round of infections. And that's because most of the people, when they're tested, have viral loads in this lower CT range as measured by PCR, whereas in the infectious period, they have much higher viral loads that can be identified by almost any test out there. And this has not only been addressed in academic articles and commentary by Michael Mina and Roy Parker and others, but also in the lay press in articles that were in the New York Times or the Washington Post. And so the testing modality that we've started using is something called RT-LAMP. And I don't want to get too far into the technical details of RT-LAMP with this audience, but to compare it to a test that I think we're all familiar with, such as PCR, which is obviously the gold standard test. Every test when compared to PCR is less sensitive. PCR is clearly the most sensitive test. It's also a quantitative test. You can look at the threshold cycle at which a sample gives signal, and you'll have information quantitatively about how much virus was in there. RT-LAMP is different it's similar in that it uses primers to amplify regions of the viral genome after a reverse transcription step. The primer setup is a little bit different, and instead of getting discrete units of PCR product, you end up with high molecular weight DNA amplicons, which you can measure via many of the same ways that people measure DNA production during RT-PCR. One difference, though, is it's an isothermal reaction, and this is really important. We actually do our RT-LAMP test, as I'll show you, in a PCR machine, kept constant at 65 degrees Celsius. But what RT-LAMP allows for is the ability to run this test without technology like a PCR machine, which also makes it extremely valuable in terms of a tool that can be utilized to do something like school surveillance. When one compares RT-LAMP to PCR in terms of sensitivity, what they find, and this is from an article that was on bioRxiv a few months ago, it might be published online now, but in general, people with these very high viral loads, meaning low CT values, are very reliably detected by RT-LAMP. And where RT-LAMP starts to fail is at these very low viral loads, these very high CT individuals. And right now, these are somewhere on Twitter, there's two scientists fighting about whether or not these individuals are infectious at all. And without taking a side of that argument, I would just say that clearly the goal of a surveillance program should be to identify those clearly much more infectious individuals. And RT-LAMP is very effective at doing that. So to compare RT-LAMP and the test we do to other tests that we've heard about here or that you might be familiar with, it's also important to appreciate that the test we do is a non-diagnostic test. And so what does that mean? So to compare it to an FDA approved or at least an EUA received test like Saliva Direct, this has received the FDA emergency use authorization, so it can be used as a diagnostic test. It also requires, though, a CLIA certified laboratory environment to perform the test. And there's a cost associated with this, right? As a non-diagnostic test, when our workflow is very similar, the primary difference is that we heat and activate our tubes in lab before we ever open them, primarily for lab safety. But as the output of that test is a non-diagnostic test, we don't tell anyone they have COVID. we simply refer individuals to a diagnostic test based on guidance that I'll show you in a minute. I won't dwell on, but it's been the matter of much discussion, as you might imagine. So it's worth saying that CMS has issued guidance in late August saying that these kind of surveillance tools, which normally, if you do surveillance like this, you cannot report patient-specific information, but due to the COVID pandemic, they've advised that they will temporarily or they will have discretion in issuing citations for people that are doing things like this, meaning that you can do it as long as you follow the rules. And what are the rules? You can't diagnose anyone with anyone, and you can simply refer people to a diagnostic test. And since this continued to be a matter of some discussion, Sarah Sawyer, a colleague who I'll introduce to you in a moment in a slide coming up, actually emailed Brett Gurar at CMS to ask specifically about the use of this kind of test in the K through 12 setting. And as you can see, he confirmed that you can use a test like this as long as you do not supply a diagnosis to an individual and simply refer them to a diagnostic test. And so the test that we use, just to acknowledge the people that I guess really deserve the scientific credit, which would be David and Shelby O'Connor at the University of Wisconsin-Madison, and Sarah Sawyer and Nick Meyerson at the University of Colorado. So what I did was effectively, each of these groups came up with a recipe for chocolate cake, and I ingeniously combined them to create a recipe for chocolate cake. So all of really the technical innovation the credit has to go to them, and the protocol we use is really a hybrid of these two RT-LAMP protocols that these labs have published. And also I should say, when I was given permission to try to launch this program in the middle of August, where I had 2 weeks to establish it, David and Shelby were really the first people I reached out to, having just heard about their program, and they were simply just outstanding in their generosity and their collegiality. They invited me up there to Madison to see what they were doing. They gave me protocols with, not just what to do at each step, but spreadsheets with catalog numbers of all the things we needed to order that really allowed us to achieve something like launching a program that I'll tell you about in a 2-week period. And so to give you a sense of what David and Shelby were doing in Wisconsin, they actually do this testing, for lack of a better term, out in the wild. They'll show up with a team of 7 to 10 scientists in 2 or 3 vans and just set up right outside of a school on folding tables. But what you can see here is the technological requirements for running these tests is not very sophisticated. You need a couple of plexiglass shields, some micropipetters, and some heat blocks. And if you have those things, at a minimum, you can start to run RT-LAMP tests in a community like this, or as I'll show you, perhaps in a hard structure where we do it a little bit more at scale using a PCR machine. And I'll kind of compare the different types of tests that they do versus what we do. So when I returned back from Madison, we quickly started to look at the different ways that we could get this test going. So David and Shelby use a calorimetric version of this test, and this is certainly the most accessible version of this test, and it works quite well. And the way that it works is there's a pH indicator in the reaction solution. Phenol red, it's really the same thing that's in any culture media, if anyone here has ever done tissue culture. And what happens is, while DNA is being amplified in the tube, every time a DNA base is added to the growing DNA strand, a proton is thrown off. And there's explosive DNA amplification in these reactions, and ultimately that will turn the media yellow. So you can see in their original bioarchive study, here's an individual with a relatively high viral load, and by taking before and after pictures of the samples, and they do this because the pH of individual people's saliva can differ, and you really want to see how much pH change occurred during the reaction versus, have they had orange juice in the last 2 hours. But what you can see here is this test can be reliably used to identify people that have high viral loads very effectively, or in some cases, even lower viral loads, although then the result tends to be a little bit more open to interpretation. And we got this version of the test working in lab very quickly. using both controls for human RNA and COVID RNA, where we've spiked in here compared to the control here. But what we also started doing was utilizing a fluorescent version of this test in which we can put it in a real-time PCR machine. And now there's a cyber green-like dye that intercalates into that double-stranded DNA. And when you have the formation of that DNA, then you get fluorescence, as you can see here. These are really the same samples that we ran over here. And we can either run those with human primers, which both samples that we ran came from humans, which was reassuring. And then the one sample where we had added COVID to, you can see a nice signal here. And so based on this, we got this version of the test working actually the Monday before we collected samples on Thursday for our school district. And so what we then did, and I should have introduced myself a little bit better, and I apologize for that. Not only am I a molecular virologist at the University of Loyola, but I'm also on the District 102 school board. And the reason that we started doing all of these things is because over the summer, I was tasked with setting up a program to get back into school safely. And everyone's definition of safely was a little bit different. So towards the end of the summer, I got permission to try to launch this program in a very short time window. And this was, I think, the Monday before the Thursday that we did collections. And what we had to do is really organize a series of things to kind of all hit the same place at the same time to allow these collections to occur. And one of the first things we needed to do was we needed to get a collection method whereby everyone could spit in a tube, but we wouldn't know their identity for reasons of HIPAA, or if you don't live in America, patient confidentiality issues. And so what we did was, and this was people in my community while I was working out the science, people that either worked in our school district or volunteered, came up with a system to develop barcodes that we could put on individual tubes that would be associated with individual participants. And then teachers and the nurses in the district, the days before our collections, literally spent days attaching these individual labels that you can see here to these Eppendorf tubes, and then putting them in little packets for the kids to receive when we actually began testing. And so we also had a very tight window to establish a lab. And so in my school district, there's a science center where in any other year, kids will get bused to the science center for little half-day field trips. Jeremy has actually been there to visit. There's fish and there's parrots and all kinds of animals. And kids will normally get to pet the snake or play with, rocks or have another tactile science experience. But in 2020, no one wants to get on a bus and you can't be trading anything from student to student. So it's basically on ice. So we were able to commandeer this science center. And with the help of my lab manager at Loyola, Jessica Maddock, we were able to quickly put together all of the supplies we needed to launch a testing program, which in a nutshell is pipette tips, pipettes, a multi-channel pipetter, some heat blocks, and other things. I started out with a rather ragtag group of assistants about 12 days before, or 11 days before we launched our program. But eventually we brought people with more initials next to their name to help get this program going. This person here, Adarsh Dharan, is a research assistant professor in my lab, and he's really was one of the key people to help get this program going, donating a lot of his time. And also my colleagues at Loyola were exceptional. Many of the things we ordered didn't arrive on time and weren't going to be there. And there was actually a faculty meeting where I had to say rather sheepishly, I really need help. Does anyone have heat blocks, pipette racks, these kinds of things, or tube racks? And I wheeled a cart around my department, and people were literally taking hot plates while they were still hot off of their bench and putting them in my cart so I could take them back to the science center to try to get this working. And so really through a kind of a real community effort that involved a lot of people going out of their way to help us, including here, I should say, the chair of physiology at Loyola, when we decided we wanted to use a PCR machine to do this, I was like, oh, well, all I need to do now is find a real-time PCR machine in about 3 days. And here's Adarsh Dharan wheeling, wrapping a QS3 PCR machine that we were able to wheel out of my research building at Loyola and take over to the Science Center and borrow for a period of 3 to 4 months. She was ridiculously generous. in allowing us to use that machine. And so the other kind of thing that happened that was a bit of a miracle was just the way that people at my institution or even the community came to help launch this. And people from my department, including many people that you can see in my lab here, really just came in, didn't ask for anything except they came with the willingness to work a 12-hour day to try to make this work, including and one of the magic things about this kind of community surveillance that is important in the context of a school discussion is that it really kind of brings two groups together. So Relia Popovic, for example, is a PhD who had spoke in our board meetings about the dangers of opening schools, and he was not in favor of it. But when he heard about what we were doing, Relia came in and helped us just immensely, working in lab to try to get this to work. And the thing about this kind of testing is it gets the open up my school at all costs, my kids deserve it crowd, and the hesitant teachers who want to be with those children but want to do it safely, instead of throwing food at each other, they actually start pulling on the same end of the rope when they get behind an idea like this. And in America, in addition to the science working out, that might have been one of the bigger miracles. So what do you have to do aside from the science to make something like this work? Well, a key element is communication and coordination. And we made videos showing how easy it was to submit in a small Eppendorf tube. We were able to do that in English, this is my wife here, or in Spanish, this is my board president here. And we shared these videos on YouTube. We had examples of kids spitting. My son received some level of notoriety in his classroom because he was the spit guy that everyone saw in the instructional video. So that was really nice for him. And we also had just community volunteers during our first collection just come out and be ready to go. Nurses showed up to collect the samples. Other people were there to distribute the kits or to provide instruction or to have people sign consent forms that I'll talk to you about in a second. And so it really took a village to make all of this come together, but it kind of took on a life of its own where all I had to do was kind of steer the tiger while I was riding it, and we were able to get to the right place. So,
and we're just going to have to switch to Christina in just 1 minute.
Sure. So I'll just go over the basics of the test, which are, a very simple scanning in and pipetting of these samples, which can then be run on a PCR machine or the calorimetric version of the test that I'll show you. And just to kind of real quickly give you some of the data that we have so far, we have a number of dashboards from the schools that we're working with. And so far, we've identified 68 people in our original school district, somehow miraculously without a false positive yet. And that's in about, at least 25,000 tests since the end of November. And you can see that these data track very nicely with our state data and the data that we're seeing at Safeguard in terms of percent positivity. We're also doing a number of high schools, New Trier being one with the best dashboard, and you can go see this data on their dashboard since I'm a little bit light on time. And so since I'm short on time, I'll just kind of skip to the acknowledgements. I think I've acknowledged most of these people throughout the talk that all kind of came together to make a program like this work. And then the other thing I would say is, I certainly am karmically indebted to the people that helped me get a program like this going. So if you want protocols, supplies, catalog numbers for those supplies or advice, please don't hesitate to reach out to me, and I'll be happy to give you whatever you need if this is something that you think might work in your school district or community.
Thank you very much, Ed. That's excellent. It's a really exciting project, and we will be following up on questions on the Slack. So please, reach out. Very interesting and a lot of resources there. So thank you very much, Ed.
Thanks.
And now we're going to switch to Christina Holt. And in the interest of time, just because I know Christina does have to leave at 11:30, she's the Assistant Director of the Center for Community Health and Development at the University of Kansas, and is going to be talking about the really excellent resource, the Community Toolbox. So Christina, it's very nice for you to be here.
It's great to be with you all today. I'm looking forward to sharing some free online open source resources for building capacity to strengthen the public health and community response to COVID-19, as well as participatory and monitoring and evaluation of a local COVID-19 response in the public health system. So I'm from the University of Kansas. We work to support community health and development through participatory research and evaluation, teaching and training, and technical support and capacity building. The first thing I'm going to share with you about, we serve as an academic health partnership with the Lawrence Douglas County Health Department. And with support from the Kansas Health Foundation, we adapted a methodology that we are using with our partners at the World Health Organization and the African Regional Office with 47 countries in order to support understanding of community-wide COVID-19 response efforts, of course, and in order to flatten the curve and reduce transmission. The goal is really providing data to inform implementation efforts and to better understand what it takes to respond to the current pandemic, as well as prepare for future outbreaks. So just briefly, I will share about these efforts to document and evaluate the local response and recovery effort. This is a screenshot of our dashboard utilizing the online community checkbox evaluation system that is being used to document local response and recovery efforts.
Christina, we can't see your slides. If you could just activate the screen share.
Thank you so much.
Perfect.
All right, is that working now?
That's perfect, thank you.
Thank you. Okay, so this screenshot basically shows the platform that we're using for systematic documentation of the community accomplishments. It's been done from document abstraction and interviews with key stakeholders locally, folks like the local emergency management administrators and elected officials, hospital and other healthcare providers, local schools and local service providers. So we're able to use this data to look at things like the distribution of activities by goal, by sector of the community, by vulnerable population being reached. We have been working with partners to identify what they see as enabling factors of the local response effort. And those have included things like local public health department size, experience, and capacity, existing collaborative relationships, having a unified structure in place, experience and capacity, equity advisors serving on various unified command working groups, joint risk communication efforts, expansion of testing, disease investigation guidance, adoption of the National Incident Management System, establishment of recovery coordination teams, funding, and early school decisions that helped enable planning, as well as political support from local elected officials. Also identified by local stakeholders have been factors that may have impeded local response activities. And those factors include our Kansas legislature limiting the governor's pandemic response power, social and political pressure to allow gatherings, lawsuits against the local health department and against the local city and county governments, COVID fatigue and easing up on precautions prematurely, limited in-person contact sometimes made it difficult for conflict resolution, certainly increased in competing demands on staff, prolonged stress on staff responsible for managing the pandemic, and ambiguity about future funding to support staff and resources needed for response activities. So next steps in the initiative include continued partnership with local stakeholders on systematic documentation of local activities, continued sense-making sessions with partners to review and utilize the data to support their local implementation efforts, and continued dissemination of the learnings. Another part of our center's mission is really around supporting research to action, knowledge dissemination that supports community building efforts. So I'm transitioning now to share with you some of the free open source resources of the Community Toolbox to support any sort of community-based efforts. So certainly the goal is supporting a competent and diverse and distributed workforce, people that are taking action in their counties and communities worldwide. Our vision is really that people would have the tools and resources to take action to change conditions that affect their lives. And the Community Toolbox contains thousands of pages on skill building guidance for collaborative community-based efforts, supporting folks working on wicked challenges such as the COVID-19 pandemic. And we have created a specific coronavirus response toolbox, which I'll be sharing about here quickly. Just to mention though, the approximately 7,000 pages of the Community Toolbox are available not only in English, but have been translated and culturally adapted for Spanish, and also partially made available in Arabic and Farsi as well. The audience is really for any community members who are wanting to take action in their communities, from grassroots volunteers and coalition members to nonprofit personnel and the private sector funders, and of course local and state and national and international agencies. So I'm just going to briefly share with you that this coronavirus response toolbox is sort of a mashup of the free and open source resources of the Community Toolbox, as well as a number of other global resources that can be put to use by communities for the COVID-19 response and recovery effort. If you visit the Community Toolbox, which is just ctb.ku.edu, you can access the Coronavirus Response Toolbox from the home page. And this response toolbox includes a number of free tools and resources for public health action and community action, including guidance for communities, which reaches into a number of freely available online resources, as well as resources for communicating the pandemic threat and response, data, how to protect oneself and family, and guidance for health workers. We've also been working to distill a number of examples of communities taking action in the face of the pandemic. And so we've been partnering with the Society for Community Research and Action and the European Community Psychology Association that are working on a new bank for community ideas and solutions in response to the coronavirus outbreak. So there are scores of examples of how communities are taking action that are organized in different areas such as the arts, food, housing, inspiring hope, and mutual aid networks. Additionally, the COVID response toolbox reaches into some select highlighted resources from the Community Toolbox to support the basic phases of engagement and collaborative efforts, from assessment to planning, of course, community engagement, taking action and intervention, and evaluating and sustaining efforts over time. Another resource that I thought I would mention is the Troubleshooting guide that's available on the Community Toolbox. It is it lists a number of common dilemmas for collaborative community-based efforts. So for example, one of the dilemmas is facing opposition or conflict. And if you drill down into one of those trouble statements, so number 7 in this example, it offers a situational assessment that provides reflection questions for consideration, as well as links where the user can drill down into more resources where that might be appropriate. One thing that I should mention is that because of the beauty of online resources that are free and open source, we are able to partner to support other initiatives that are working to build capacity for collaborative action. These are just a few of the groups that we partner with to support capacity building efforts. And we certainly welcome partnership for linking into and using the resources as they're available. Certainly, we have a Creative Commons license for share and share alike with attribution. So if any of the free resources can be helpful to your own initiatives, we hope that you will feel free to use those. Additionally, we are always looking for and glad to receive additional tools and resources and success stories that can be added online to the community toolbox and shared with the approximately 6 million people worldwide who access the resource each year. And of course, we're ongoingly looking for partners in the translation and cultural adaptation resources. So if you're interested in visiting the community toolbox, I've put the URL up here. I'm also going to place my contact information here if anyone is interested in being in touch. And then I would love to hear any questions that you all have or any reflections on these online resources for capacity building and systematic documentation of community-based efforts.
Excellent. Thank you very much. It's a wonderful resource and absolutely great to hear about. So we have just a couple minutes. Does anybody have any questions? So to begin with, how, there's a lot of collaboration opportunities that are present. Have you been getting a lot of responses from a lot of different organizations looking to collaborate to use these different resources? And if so, in sort of what fields and what spaces?
Yes, so we do, at the last time I looked, we had about 13,000 inbound links to the community toolbox from external sites, which of course we greatly appreciate the opportunity to partner like that to get the resources into the hands of people who can use them. We receive inquiries and partnerships from people ranging from, those in public health, community psychology, macro social work, applied health sciences, urban planning, a number of kind of applied fields that, really rely on community engagement to tackle these tough challenges.
Excellent. Thank you very much. So if anybody has any further questions for any of the speakers today, please join us on the Slack channel, the sessions tools #1. So we'll continue the conversation, and thank you all very much. So with that, I'd just like to thank all the speakers today. So thank you all for wonderful talks and a really, really interesting conversation, a lot of excellent tools and resources. So thank you all very much. And with that, I'd just like to say, everyone, please thank all the speakers, and we will be reconvening in about a half an hour at 12 p.m. Eastern to talk about vaccine hesitancy in an interactive workshop. So thank you all very much for coming.